Good evening. So today we'll be discussing the second half of developmental dysplasia of the hip, mainly targeting children above 6 months of age.
Nandhini, louder, please.
Yes, ma'am. So just a refresh, the DDH is a spectrum of hip joint abnormalities that range from mild acetabular dysplasia to complete femoral head dislocation due to improper seating of the femoral head within the acetabulum. It evolves over time, which means that embryologically the structures that make up the hip joint are normal, but gradual abnormality occurs due to varying reasons which have already been discussed previously in the etiopathogenesis. So it basically classifies as a deformation. So the main components here are that concentric reduction of the femoral head is required for an adequate balance of forces between the acetabulum and the femoral head and triradiate cartilages for adequate and normal development. Any imbalance that occurs during fetal development and postnatal growth will result in abnormal hip development and dysplasia. So the spectrum basically varies from instability through dysplasia, through dislocation, or through dislocation that is present at birth, or congenital or teratological dislocation. So instability is basically characterized by a positive Barlow-Ortolani tests in infants, neonates, and the evidence of instability can also be seen on ultrasound. Invariably, this may spontaneously reduce within the first 6 months. If there is dysplasia, there will be a shallow acetabulum with increased obliquity. However, the Shenton's line will be intact. If there is dislocation, the femoral head and acetabulum will not be entirely in contact, and the Shenton's line will be broken. Whereas if there is a teratological dislocation or dislocation at birth, there will be the femoral acetabular contact will be completely disrupted, and this will be fixed in that there will be limited motion and the hip will not be relocatable. So in walking age children, ma'am, 1 second. Sorry, is my screen still visible?
Yeah, very much.
1 second.
The video is not working though.
1 second, ma'am. Okay. So in sorry. Okay. I think there's a bit of a problem because the slides are not moving. 1 second. Sorry.
Share the presentation with someone else. Maybe Shivam can run it or what.
What happened? Internet problem?
Just be a little patient with that video, I think. Probably the lag is there. Yeah.
So basically the clinical presentation in walking age children, they can either present depending on whether it is a unilateral or a bilateral DDH. A bilateral DDH usually comes with a waddling gait and exaggerated lumbar lordosis, whereas a unilateral DDH will come with a Trendelenburg gait with a limb length discrepancy, a positive Alice-Galeazzi sign, and limited abduction range of movement. So the physical examination findings by age for DDH have been summarized here as we discussed. Radiologically on X-rays in walking age kids, usually X-rays are preferred because USG is done only up to about 3 to 4 months. So here we basically look at the acetabular index, and if the ossific nucleus has formed, then the position of the edge point on the proximal femur metaphysis in relation to the quadrants that are developed between the Hilgren-Renners and the Perkins lines. So the Hilgren-Renners line is basically a horizontal line that passes between the two triradiate cartilages, and the Perkins line is a perpendicular to this that is drawn along the lateral border of the acetabulum. Depending on where the edge point is situated, normally it is found in the inferomedial quadrant. However, if it is displaced out as in a DDH, depending on whether it is in the second or third quadrant, which are basically equal halves of the inferolateral quadrant, or in the superolateral quadrant, it is classified as IHDI 2, 3 and 4 subsequently. In addition to this, we also see the continuity of the Shenton's line. The acetabular index is measured as the angle between the acetabulum and the Hilgren-Renners line. It is usually less than 30 degrees in a newborn. Progressively, it decreases further and is said to be dysplastic if it is even more than 20 degrees at about 2 years of age. So the angle formed by the Hilgren-Renners line and the line drawn along the acetabular surface to the lateral edge of the acetabulum. So as we discussed, less than 30 degrees at birth, around 20 degrees at 6 months, and it should be less than 20 degrees at 2 years of age. After the triradiate cartilage closure, a horizontal line can be drawn from the inferior tip of the teardrop to the lateral edge of the acetabulum, and this is called as the Sharp's angle. Sharp's angle should be less than 40 degrees. The treatment objectives in DDH are to obtain a concentric reduction for normal functioning long term, to maintain the stability of this reduction that has been achieved until growth is complete, and necessitates follow-up until skeletal maturity to ensure the same, to stimulate normal growth and development of the hip. So obtaining a concentric reduction with redirection of joint forces is key to normal development of the acetabulum as well as the proximal femur, and to prevent complications, particularly compromise to the blood supply of the proximal femur and arthritis and femoroacetabular impingement. So the gold standard normal hip at maturity is basically an intact Shenton's line, a well-developed and appropriately shaped teardrop, downsloping sourcil, and normal Gothic arch above the sourcil. That is the Gothic arch above the sourcil here. So basically, Pavlik's harness was discussed for children for the age group of less than 6 months last time. The maximum waiting time for reduction in a Pavlik's harness is 4 weeks. If there is prolonged application of Pavlik harness despite an unreduced hip, it results in posterior acetabular insufficiency or Pavlik disease. Other complications that can occur with the Pavlik harness are femoral nerve palsy or an inferior obturator nerve palsy if there is inferior dislocation, and hyperabduction, which can result in AVN. More than the age as a deciding factor for the application of a Pavlik harness, which we normally roughly take as 6 months, the size of the child and the ability of the child to turn prone are more major limitations. This means that if the child is relatively smaller or has not attained the ability to turn prone yet, but is probably more than 6 months, it might still be a candidate for Pavlik harness application. So discussing today's topic mainly, that is beyond the age of 6 months. So from 6 to 18 months of age, or patients who have failed the Pavlik harness, the next step is to try and attempt a reduction. This reduction is usually attempted close first. In case of failure of close reduction at the outset or subsequently, open reduction is subsequently attempted. This may or may not be coupled with a femoral or pelvic osteotomy. There have been some instances where pre-reduction traction has been discussed, but there are contradicting opinions of the benefits of the same currently. In our practice, we do not give pre-reduction traction. However, it has been reported that there are some reduced risks of AVN with pre-reduction traction in literature. So closed reduction is usually done under anesthesia. An arthrogram of the hip is done to confirm the reduction. It can be coupled with an adductor zoastenotomy if needed. The hip is adducted. After reduction, the hip is adducted to the point of redislocation, and that position is noted. This hip is again reduced with abduction and flexion to bring the GT up as in an Ortolani maneuver, and then extended until it dislocates again, and the point of dislocation is noted here as well. So these arcs basically represent the safe zones of Ramsey. The aim is to immobilize the hip within the safe zone without extremely abducting or flexing it. This is usually possible in an abduction range of about 45 degrees and a flexion of about 90 degrees, or the human position. So for closed reduction, in the supine position under GA, longitudinal traction with flexion abduction is attempted, basically the Ortolani maneuver. This gentle maneuver can be a palpable reduction can be felt at this point, and subsequently an arthrogram is done to check the reduction. Along with this, we also need to check stability. As discussed earlier, you check for the point at which on adducting it redislocates and on extending it redislocates to chart out your Ramsey zones. So the arthrogram should show a typical rose-thorn sign if an adequate reduction has been achieved. So the point of redislocation in sagittal coronal planes have to be recorded. Along with this, the amount of rotation that is required to keep the hip stable should also be recorded. If more than 15 degrees of internal rotation is needed, then it is considered to be unstable, because severe extreme internal rotation positioning can increase the risk of AVN. So the stability markers are the degree of internal rotation required and the safe zones of Ramsey that can be recorded, and the feel of the reduction as well. If the reduction is stable, this is followed by the application of a hip spica in human position for about 6 weeks. So a successful closed reduction is basically one where the reduction is adequate and it is also stable. Clinically, this depends on the feel of the reduction, the tightness of the structures, the charting of the Ramsey safe zones, and then under C-arm, we also look at articular congruity, through range, Shenton's continuity, and an intraoperative arthrogram. If the width of the medial dipole is more than 6 millimeters, it is suggestive of a poor reduction. So the probable obstacles that can occur to a closed reduction are extra-articular obstruction because of the iliopsoas tendon or the adductors, and intra-articular factors like the inverted hypertrophic labrum, the transverse acetabular ligament, the pulvinar ligamentum teres, and the constricted anteromedial capsule, especially in late presenting cases. So the neolimbus is not an obstacle to reduction and represents the epiphyseal cartilage of the acetabulum. It should not be removed as it impairs further acetabular development. So this is again an overview of the structures that can limit a closed reduction in DDH. So post-reduction factors that can cause persistent instability or redislocation are any redundant superior capsule, if there is significant acetabular dysplasia, or if there is coxa valga and excess femoral anteversion. So children who have failed a closed reduction, or children usually above 18 months of age, we opt for an open reduction. So in open reduction, this could either be attempted via a medial approach or an anterior approach. So we usually in our practice choose to do an anterior approach. However, medial approach has also been advocated in some places, with the advantages of minimum dissection and the ability to approach the obstructions more directly. So the medial approach, there are two approaches that are described. One is by Ludloff and one is by Weinstein. So the difference between the two is the interval. Usually the Ludloff's approach goes between the pectineus and the adductor brevis, whereas the Weinstein's approach goes between the femoral neurovascular bundle and the pectineus. That is, it is anterior to the pectineus. And this description is of the Weinstein approach. So we take a medial approach that is slightly lateral to the groin crease. After this, we cut open the fascia over the adductors. The adductor longus is identified and divided. After this, the adductor brevis and the overlying pectineus is identified, and the branch of the obturator nerve over the adductor brevis is identified. And a plane is usually made anterior to this pectineus between the femoral neurovasculature and the pectineus, and this directly opens up to the capsule. We need to be careful of the medial circumflex femoral artery in this approach, as it comes right in the center, passing from superior to inferior, and needs to be preserved. So the capsule is usually opened up along the incision line only, and then after this, the head is again relocated as in the usual maneuver that we do with flexion abduction, and along with that, the ligamentum teres is identified, traced to the base of the acetabulum, and the rest of the procedure is similar to that what is done in an anterior approach. Along with this, the transverse acetabulum also has to be cut. Sometimes this is coupled with tracing the iliopsoas tendon and releasing it, and the capsulorrhaphy is then done ultimately, and this is closed with subcut and skin. The anterior approach is the standard Smith-Peterson approach that we take. So here the incision is a bikini incision that we take about a centimeter distal to the anterior superior iliac spine. This is centered over a line that goes from the ASIS to the center of the patella. So it has to be equidistant on either side of this. And after taking our routine skin and subcute, we basically identify a color difference between the TFL and the sartorius and develop a plane through this internervous plane. Then further, along with this, we also have to identify the lateral femoral cutaneous nerve and retract it safely. In order to be able to retract this easily, we may have to dissect the fascia more superiorly up to the inguinal ligament. Then after this, usually the sartorius is released from the ASIS for better exposure. After that, we go to the deeper interval between the rectus femoris and the abductors. So subsequently, that is also developed. Then the origin of the rectus femoris from the AIS is also released. The rectus femoris head is also released. And then we develop the plane between the abductor capsular interval. And along with this, we also identify the iliopsoas at the brim and release it. And then after that, a capsulotomy is done. Once the capsulotomy is done and the femoral head is identified, we trace the ligamentum teres to the base of the acetabulum. At this point, we can release the ligamentum teres from the femoral head and then from the base of the acetabulum as well, clear out the pulvinar. Ultimately, the transverse acetabular ligament is also cut with scissors. And after all these impediments are cleared, a reduction is attempted. Either we may get a easy reduction with flexion abduction at this point, or if it is a chronic case or an older child or a teratological hip, this may have to be coupled with a femoral shortening osteotomy to get adequate reduction. In order to maintain the reduction, a transarticular K-wire put as a holding K-wire may be passed into the superior pubic ramus. And ultimately, this is closed after doing a thorough closure with a capsular raphe. So apart from the open reduction, sometimes we may need to add a further step either in the form of a femoral or a pelvic osteotomy as the need may be. So the indications here are that, for instance, if the reduction is not possible because of a chronic case or an older case, we may have to shorten the femur, or if the hip is stable in too much of internal rotation only, which is going to increase the risk of AVN, we may have to couple a derotation osteotomy at this point. If after the reduction and the femoral osteotomy, we feel that the acetabular dysplasia is too much, then we may have to also add in a pelvic osteotomy after this. So shortening osteotomies may be necessary to enable reduction. Shortening is also needed if the hip is so high riding that it is unstable following reduction due to increased tension. And a femoral shortening osteotomy reduces the tension on the femoral head and reduces the risk of AVN. A varus osteotomy may be needed if the hip remains stable only in wide abduction, and derotation osteotomy after open reduction if the anteversion requires significant internal rotation for the reduction to be stable. It reduces the need for extreme internal rotation and the postoperative cast and the position, reducing the incidence of AVN and avascular necrosis. So varus plus derotation may sometimes be necessary together. So a standard lateral exposure is done to the proximal femur. Here, after cutting through the skin and subcute, the TFL is identified and incised. After the TFL is incised, we basically need to identify the bare area, which is usually located just above the gluteal sling. So deepening through the bare area, we can create periosteal flaps to expose the proximal femur laterally, and then continue the incision proximally up till the greater trochanter, where an anterior horizontal extension is made to lift off the soft tissue, and inferiorly, after retracting the vastus lateralis with retractors, we can safely dissect most of the vastus lateralis also without compromising too much of the blood supply through the perforators. Once the bone is fully exposed, then the osteotomy is done at a subtrochanteric level. Either a transverse osteotomy is done followed by rotation and fixation with a plate, or if required, a shortening osteotomy is done with a wedge of bone that is removed to shorten the femur. Both of these can also be combined sometimes together. In the event that there is an acetabular dysplasia, the presentation of this acetabular dysplasia will also be coupled with whether the hip is congruous or not. So if there is concentric reduction or a congruous hip, the possibilities are there will be abnormal orientation of an acetabulum that matches the size of the femoral head, or the acetabulum may be too large or capacious for the femoral head. That means that the femoral head may start riding laterally. This also is represented in the form of a very elevated acetabular index. If it is an incongruous hip or incongruous reduction and there is no concentric reduction that is obtainable because of the dysplasia, that is the other category that we see. So the pelvic osteotomies are broadly divided into reconstructive and salvage osteotomies. Reconstructive osteotomies are basically further divided. So reconstructive osteotomies can be used only when the hip reduction is concentric. That is, reduction is possible. And here the reconstructive osteotomies can be further divided into either reshaping osteotomies or reduction. Here reshaping means that the capacity of the acetabulum is reduced, or reorientation osteotomies or redirectional osteotomies. The redirectional reorientational osteotomies preserve the volume of the acetabulum. Here the volume remains unchanged, but the direction of orientation changes. So examples are your Pemberton, Degas and San Diego for the reshaping reduction osteotomies, and your Salter or single innominate, double innominate and triple innominate osteotomies, as well as the Gans periacetabular osteotomy are examples of your redirectional osteotomies. In salvage procedures, there is a non-concentric reduction or a non-congruous hip. Here, augmentation has to be done. It is one of the only volume increasing osteotomies where extra coverage is provided to the unreduced femoral head. Here the examples are the Kyrie or the shelf or Stahel's osteotomies. So just to quickly describe each of these, the Pemberton's osteotomy is a periacetabular osteotomy directed posterior-inferiorly from the AIIS, usually performed when the triradiate cartilage is still open between 1 to 10 years of age. It improves anterolateral coverage and can bring about more than 15 degrees correction of the acetabular index and hinges on the triradiate cartilage. So it is basically an incomplete osteotomy with the lateral iliac cut starting equidistant between the anterior superior and anterior inferior iliac spines, parallel to the hip capsule and stopping at the ilioischial limb of the triradiate cartilage. Following this line here, and a graft is placed. This is a post-op X-ray after Pemberton's osteotomy showing a healed pelvic osteotomy. In Degas osteotomy, it is quite similar to the Pemberton, except that it can provide better lateral coverage than the Pemberton's osteotomy. And here the hinge is not only at the triradiate cartilage, but if a significant amount of posteromedial cortex is intact, then it can also hinge posteriorly. So the acetabular coverage can be increased anteriorly, centrally or posteriorly. So it is a little more modular than the Pemberton's depending on the placement of the bone graft wedge. So as you can see, it is an incomplete osteotomy of only the lateral ilium that hinges on the triradiate cartilage. Here we don't go directly towards the triradiate cartilage. We exit above it, but keeping the medial cortex intact. And the posterior column and posterior cortex are also preserved. If the posterior cortex is also breached, it becomes a San Diego's osteotomy. So another thing to keep in mind here is that a combination of both curved and straight osteotomes need to be used, and depending on the amount of the inner cortex that we leave intact, we can basically use it more for anterior coverage versus lateral coverage. So just to explain this, if we go more in medially, that is more towards the inner cortex, and compromise most of the inner cortex, then we end up hinging the distal fragment more anteriorly. So this provides better anterior coverage. Whereas if we leave more of the inner cortex intact, then we end up hinging it more laterally. So this provides better lateral coverage. So basically, the rotation becomes more anterior as more of the inner wall is divided, and the rotation becomes more lateral as more of the lateral wall is left intact. Additionally, placement of the bone graft can also vary depending on where we want better coverage. So in CP hips, where posterior coverage is more important, this is a better choice of an acetabuloplasty. So this is an example of a radiograph post Degas osteotomy with bone graft placement at the wedge. So coming to the reorientation osteotomy, Salters has described the single innominate osteotomy can be performed between 18 months to 6 years, The hinge here is a pubic symphysis, and the advantage being that it is technically easy, but disadvantages being it increases limb length and can cause femoral nerve stretching and palsies. So based on the redirection of the acetabulum as a unit by hinging on the and rotating through the symphysis pubis, it is done when the head is reduced or can be reduced with open reduction. However, the coverage provided is lesser than that of an acetabuloplasty like Pemberton or Degas, which means that it can be attempted if less than 15 degrees of correction of acetabular index is required. So the osteotomy here is basically from the sciatic notch to the antero-inferior iliac spine, and with the hinge being at the pubic symphysis and the sciatic notch. Okay, so the osteotomy is made from the AIS to the greater sciatic notch, and then after redirecting the distal fragment, bone graft can be placed and fixed with K-wires. Post-operatively, 1.5 spica is applied with the limb in 20 degrees of flexion and 30 degrees of abduction. With neutral or slight internal rotation, it has to be continued for about 6 to 8 weeks. In case of open reduction, this can be extended up to 12 weeks. K-wires can be removed after about 6 to 8 weeks depending on radiographic union. The double innominate osteotomy of Sutherland is basically a Salter's innominate osteotomy coupled with a pubic osteotomy through the conjoint portion of the pubis. Again, here the fragment is reoriented. The Steele's triple innominate osteotomy is basically the Salter's plus the pubic osteotomy along with an osteotomy through the ischium. The advantage here is that it allows free motion and redirection of the acetabulum, but the amount of rotation is limited by sacropelvic ligaments. The pubic rami is approached through a separate groin incision. So along with the standard Smith-Peterson approach, a second incision has to be taken medially, and it alters the true pelvic dimensions. So post this osteotomy, normal delivery may not be possible because the volume of the true pelvis may be affected. It is indicated in irreducible subluxation or dislocation and failure of other osteotomies. So here the osteotomy is from the sciatic notch to the anterior inferior iliac spine, and the ischium and the pubic rami are done, which hinge on the pubis and the sciatic notch. Difference between Steele and Tonis is the exit point of the ischial osteotomy, which is below the ischial spine in Steele and above the ischial spine in Tonis. So Gans has described the periacetabular osteotomy. It is the osteotomy of choice in skeletally mature patients or adolescents above 12 years after the triradiate cartilage has closed. It helps to achieve correction with containment and congruous joint with less arthritis in the future. It is easily combined with the trochanteric osteotomy, preserves blood supply to the acetabular fragment, and the true pelvis volume remains unchanged in this. So the surgical approach is via Smith-Peterson. Osteotomy cuts, there is a partial incomplete cut of the ischium, a complete osteotomy of the pubis, and a biplanar roof osteotomy of the ilium. It is contraindicated if the triradiate cartilage is open, as it can cause crude disturbances. So this, in this osteotomy, the osteotomies are performed at the pubis, the ilium and ischium. It allows for extensive acetabular orientation and can only be performed when the triradiate cartilage is closed. So we have a complete pubic osteotomy and a partial ischial and iliac osteotomy, leaving the entire posterior column intact. And then this fragment is reoriented and fixed with K-wires and bone graft. So this is an example of a radiograph post Bernese-Gans periacetabular osteotomy. So coming to the salvage procedure. So in case the child is older, or if a concentric reduction has not been obtained, or if there is dysplasia leading to redislocation that is not completely reducible, then we can opt for a Kyries or a shelf acetabuloplasty. Both are examples of salvage procedures. So here a transverse osteotomy of the pelvis is done above the level of the cranial insertion of the capsule. Then the distal acetabular fragment is displaced medially. So the head is completely covered with the acetabular roof, and it covers well laterally, usually performed after around 8 years of age. Indicated if the hip is still painful, incongruous and subluxated, and no other options are really left. So it is basically a salvage procedure, increasing the volume of the acetabulum and lateral coverage. So there is a complete iliac osteotomy that is done following the plane between the reflected head of the rectus femoris and the hip capsule. It exits posteriorly into the sciatic notch and anteriorly through the anterior inferior iliac spine. It is angled approximately 10 to 15 degrees cranially. The distal fragment is then displaced medially relative to the proximal fragment and fixed with either screws or wires. Example of a radiograph post-Achilles osteotomy after complete healing and implant removal. Chelf's osteotomy by Staheli, again preferred above 8 years of age, augments the superolateral deficiency in the for proximal femur coverage and prevents subluxation of the head, increases the load-bearing area of the hip joint. Indications are again similar to Chieri's osteotomy. So here shelf is created little above the intact labrum along the capsular attachment, and then bone graft that can be harvested in the form of slips of intact outer cortex from the iliac crest can then be stacked over here to create a shelf. This may either be left in isolation or it could be augmented with an implant such as a recon plate that holds it in position, where the recon plate is bent such that it is then fixed with a single screw above the graft in the iliac bone. So it is an augmentation of the lateral acetabulum with placement of strips of corticocancellous bone graft between the hip capsule and the reflected head of the rectus femoris. It is a salvage osteotomy. There is no redirection, no hinge component. It can either be done in the form of this shelf acetabuloplasty, where the slips of bone are placed in a shelf created above the rim of the acetabulum, or a tectoplasty may be attempted. Here, basically a proximally based flap of the outer cortex of the ilium extending up to the margin of the joint capsule is raised, and then bone graft is packed under this flap to keep it elevated and creates an extended acetabular roof. So both of these salvage procedures are basically done in incongruous hips and are examples of volume increasing osteotomies. So an overview of pelvic osteotomies for DDH. Usually less than 7 years of age, we can do a Salter single innominate redirection osteotomy or reshaping osteotomy such as the Pemberton and Dega. Above 7 years of age, if the trilated cartilage is open, a Dega or a triple innominate osteotomy can be attempted. If it is closed, the options now are either a triple innominate, a Gans periacetabular osteotomy, or a spherical osteotomy. If concentric reduction cannot be achieved, then we are only left with salvage procedures such as the shelf or the Chieri's osteotomy. Factors influencing management decisions in DDH are the age at presentation, the pathology, because it is a wide spectrum that can vary between instability, dysplasia, subluxation, dislocation, obstacles that impede reduction, status of the triradiate cartilage, size of the femoral head relative to the acetabulum, and magnitude and location of the acetabular dysplasia if it is present. So just an overview of everything discussed so far. Basically, in age less than 4 months, if the hip is reducible by the Ortolani maneuver, a Pavlik harness for full-time use can be attempted, and this has to be monitored serially with 2 weekly USGs to monitor the graph scoring and the alpha and beta angles. If the hip becomes stable, then this can be weaned off gradually and then followed up till skeletal maturity. However, if the hip has not become stable in 6 weeks, acetabular development is not satisfactory after 6 weeks, then we have to follow up to column 3. Here, with their unsatisfactory response to Pavlik harness or a poor acetabular development or failure to achieve reduction, we have to examine under anesthesia and attempt closed reduction and hip spica. If the hip is not reducible by Ortolani maneuver, we can attempt a Pavlik harness for full-time use, monitor it about 2 weeks to check for reduction if it has occurred, and if reduction has been achieved, then go back to following the steps described earlier. So in age 4 months to 18 months, for those children who have failed the Pavlik harness, if the hip is reducible when examined under anesthesia and reduction is stable in neutral position, we confirm concentric reduction arthrogram described with the various things to see after doing the arthrogram, and then apply a hip spica cast. This can be confirmed post-operatively for concentric reduction using axial cuts of a CT or MRI. And sequential cast changes can be done at about 6-week intervals, and the follow-up has to continue till skeletal maturity in all cases. If the hip is reducible when examined under anesthesia but the adductors are tight, we couple this with an adductor tenotomy. And if the hip is reducible when examined under anesthesia but very unstable, there is this Ramsey's safe zone is very narrow, or there is very large medial dipooling, or the reduction feels very tight, then we usually proceed for an open reduction, followed by in our setup we apply a transarticular holding K-wire and a hip spica cast. And then the rest of it is with K-wire spica change at 4 weeks, continuation of a spica for another 4 weeks, and then a spica shell which is gradually weaned off. Follow-up has to occur till skeletal maturity. If the hip is not reducible by close means when examined under anesthesia, even after an inductor tenotomy, then arthrograms are done to identify impediments to reduction, and open reduction is carried out, again followed by hip spica application and a transarticular K-wire. In 1.5 years and above, if open reduction is indicated in almost all cases, this may or may not be coupled with a femoral osteotomy and a pelvic osteotomy as the case may require. So if the reduction is stable in neutral position with no undue tension, then open reduction without any further osteotomies is acceptable. If the reduction is stable only in extreme internal rotation or abduction and internal rotation, and we have to combine this with a derotation or varus or both. If there is difficulty encountered in reducing the hip after release of all soft tissue impediments, then we may have to go ahead with a femoral shortening osteotomy coupled with varus or derotation as the case may demand. If there is acetabular dysplasia along with this, and the child is between 1.5 years to 6 years of age, concentric reduction is achieved and the acetabulum is normal in size, then we can attempt a Salter's osteotomy. If concentric reduction is achieved but the acetabulum is really capacious or shallow, that is, there is an elevated acetabular index, then we may have to attempt for a reshaping osteotomy like Pemberton or Dega. From 6 years to skeletal maturity, concentric reduction achieved with a normal size acetabulum, we can also do a triple innominate osteotomy, if not a Salter's. And if concentric reduction is not possible or the acetabulum is small, then a salvage procedure like a shelf osteotomy or Chieri's osteotomy may be needed. At skeletal maturity, concentric reduction achieved, we can either do a triple or a periacetabular osteotomy of Gans. If concentric reduction is not possible, then a salvage procedure is attempted, usually a Chieri's osteotomy. For teratological hip dislocations that are unilateral or bilateral with severe muscular weakness and poor prognosis for walking, usually no intervention is done for hip dislocation. If the child is less than 1 year of age with unilateral or bilateral dislocation and a good prognosis for independent walking, then open reduction can be attempted by medial approach. At about 1 to 2 years of age with unilateral dislocation and reasonably good prognosis for walking, open reduction by anterolateral approach with a femoral osteotomy may be indicated. And if there is a bilateral dislocation or a high unilateral dislocation with reasonably good prognosis for independent walking from 1 to 2 years of age, then we may do an open reduction along with femoral shortening. For above 2 years of age, if it is a bilateral dislocation, we usually leave the child alone. But if it is a unilateral dislocation with a good prognosis to walking, then an open reduction by anterolateral approach and femoral shortening may be attempted. Complications that can occur are redislocation or subluxations, avascular necrosis or growth arrest, persistence of dysplasia and subsequently pain and femoroacetabular impingement, and eventually long-term arthritis of the hip joint. So, Salter has given a classification of growth disturbance of the femoral head. There are 3 described classification systems, those given by Salter, Buchholz, Ogden, and Kalamchi-McEwen. So for Salter's classification, basically, if there is failure of appearance of the ossific nucleus of the femoral head within 1 year after reduction, it is categorized as class 1. If there is failure of growth of an already existing ossific nucleus within 1 year after reduction, it is classified as class 2. If there is broadening of the femoral neck within 1 year, it is class 3. And if there is increased radiographic bone density followed by fragmentation of the femoral head, basically changes that are seen in a typical AVN, it is a class 4. And if there is residual deformity of the femoral head and neck when reossification is complete, then it is a class 5. Buchholz and Ogden system is mainly used for growth arrest. So here, if there is irregular ossification but only in the femoral head, the growth is normal and the physis is uninvolved, it is type 1. If lateral headed metaphysis is involved and ultimately results in caput valgum during adolescence, it is type 2. If the whole head and metaphyse is involved, resulting in a short femoral neck or coxa breva and a high riding trochanter, it is type 3. And if only the medial head and metaphyse is involved, it is type 4. Kalamchi-McKevin also gives a classification system where it is classified as grade 1, again if similar to Buchholz-Ogden 1, where only the head is involved with normal development and no physeal involvement. If the lateral head and metaphyses are involved, causing caput valgum and adolescence, it is 2. In 3, there is central head and metaphysis involvement. And 4, the whole head and the whole of the physis is involved, resulting in high riding trochanter and a short neck. So grade 4 of Kalamchi-McKevin is similar to our grade 3 of Buchholz-Ogden system. So recent developments, basically previously there was a belief system of waiting for the ossific nucleus to appear, but there is no longer a consensus on waiting for the ossific nucleus to appear to consider reduction. Then arthroscopy assisted reduction to reduce morbidity versus open, possibly less soft tissue disruption. Then there is some literature on preservation or reconstruction of the ligamentum teres after reduction of the hip, AI assisted diagnostics and universal ultrasound screening to help diagnose and diagnose cases early on, and advanced planning are using CT guided images and 3D printing models, especially for older age groups, to better tailor treatment and predict outcomes. Thank you.
Sandeep, your questions first or your comments first.
No, that was a good overview. This paper that you are showing, have you read about this?
So I've read it only partially. This
So,
was the one that they
interesting.
talked
So
about
what they do is, that the suture anchors which they use in arthroscopy, or uh, they are using that to construct kind of uh, the ligamentum teres. So they excise the ligamentum teres. They don't really keep the ligamentum teres, but they kind of use this suture anchor, flip it on the inner side of the pelvis and pull it. And the authors of this, do by any chance you listen to pediatric ortho podcast? There is one podcast which comes, Posna's podcast. So
Okay, sir.
on one of the episodes, the author was, there, and what he was claiming is that they have almost a 5 or 6 year follow-up now. But since they are, after a few cases of first doing this technique, they have stopped applying hip spica. I mean, he claims the hip becomes so stable that they have stopped using a hip spica. And also now, if it is a bilateral, they proceed with bilateral in the same sitting, just because he claims that this gives the hip that much stability, that once you tie that suture anchor, the hip just doesn't dislocate. So I mean, I don't know, I mean, what to comment on that, but that's what their claim is, that the hip becomes so stable after doing this. But
So there's talk of these guys,
the
doing
ligamentum
them
teres repair was first described by Dennis Wenger, and even
with,
Salil Upasni, when he was
yeah.
here, he says that he used to regular, but they just used to suture it, to that inferior transverse ligament. But this is something different. They are reconstructing with that suture anchor, which they used to reconstruct ligaments and all.
Tightrope and
Yeah,
so forth.
tightrope, exactly. I
Yeah.
was not getting that word, tightrope. They're using the tightrope, but whether it causes, this
I don't know how much it
partial growth
restricts the
arrest,
range and all that. I have heard about
yeah.
the podcast,
He,
but
yeah,
I
yeah.
haven't listened to the podcast myself.
Hey, that podcast is very good. It comes every month, and some interesting, topics they take up. And also, you should listen to it. You can even listen to it while driving or whatever. So basically, and there is one author which they take up, and also all the interesting articles which have come out in the last month. So it's quite a good podcast. The Pete
So
Ortho
I
podcast. I will
only knew
share a link.
about the Melbourne group doing the medial open reduction.
Ah.
And they used to really use the ligamentum teres as a tether itself
Yes, yes.
to which made a lot of sense because since they were going down medially, it was used to pull the femoral head
Yeah,
down.
yeah, yeah, yeah.
And they say over a period of time, it metaplases into a nice membrane, which keeps the head also better. And but I mean, there's such limited experience with the medial open reduction.
Absolutely.
Mm. So my only comment is, Nandini, the last few tables became very confusing because it was just a repetition. Um, everything at one go sometimes becomes a little bombardment, and first few slides you could have really easily done without. So
Okay,
it's
ma'am.
just started from Pavlik Harness.
Management.
Yeah. What about Kalamchi Maki? When you've given the classification, but then how is it used? What is the treatment of that? So that you should have definitely like we stopped here. But what are the treatment options? Because EDH is such a huge topic. So
Yes,
then what
ma'am.
happens is because you spend so much time on the others, you kind of feel exhausted by the time you come for this because this is one of the most dreaded complications. Of
Growth
course, the first
arresting.
one in your beginning of your career is a redislocation. But over a period of time, you realize that only when you've really either struggled or been a little too, not paying attention to the rotation and the coverage on table, that's when your redislocations happen. First few initial ones, when it redislocates, you'll just keep wondering, what did I do wrong? Then you'll realize that the trick is really in the rotation and the coverage and a comfortable fit. It's like
Yes,
what
ma'am.
they say is the DDH doesn't walk in, it doesn't stay in. Then there's a lot of talk about those jumpers and sliders and all that stuff. And those are the ones where you have a really non-reconstructible acetabulum. The shelf, I don't think anyone really uses much in DDH. It's used more in Perthes.
But these.
And AVN treatment plus the newer things of growth modulation. For
Yes, ma'am.
it was originally the
Uh,
medial hip screw actually came into vogue because of this indication, AVN and uh, hip dysplasia. Then there's a lot of talk these days about late presenting dysplasia, residual dysplasia. So maybe you could have divided your talk into compartments and we could have had part 2 and 3 later also.
okay, ma'am.
But there's a lot to read. Hip is a like kind of unending topic. All of us love it. Myself, Sandeep, Mandar, Alric, all of us love hip. So that way.
Yeah, if you decide you can have two, three, four
Two, three,
lectures
four,
on
I
it.
swear.
That's fine. Okay, but I think it was a good
Yeah, good
overview.
overview and good learning. So always now when you all are presenting now, all of you who are in your second year of the fellowship, try to refine your presentations. And since we have clinical examples, try to put them in. We have such a big wealth of knowledge in that IHDI. Hmm? So, ठीक है, good.
Okay,
See
fine.
you all tomorrow. Next week क्या है?
Perthes है ना? I think. Hello.
Yes, sir.
Okay.
Perthes है.
By
कौन सा
whom?
रहा?
By Karthikeyan.
कार्तिक है. Okay, fine.
Perthes फिर SCFE and अभी का एक टॉक है.
हाँ,
But I
ठीक.
think we are running 1 week late. तो अभी
हाँ,
को
पर
जो
चलेगा
डेट
ना.
बोल
That's okay.
तो अभी को जो डेट बोला है मे बी वी कैन कीप द सेम डेट फॉर हिम एंड SCFE 1 week ये करेंगे डिले करेंगे.
We
आई
could have
स्टिक टू
both parts of
व्हाट ही वुड
SCFE
प्रेफर.
together. Let's see how we get time.
या ठीक
Yeah.
है. चलो.
Okay.
ओके.
Thank
अभी
you.
का ये है ना हिप प्रिजर्वेशन FAI एंड ऑल दोस
Oh,
थिंग्स.
okay, okay.
एडोलेसेंट हिप.
So then simple SCFE उसके पहले जाना चाहिए.
ठीक है चलेगा. फिर अभी से बात करता हूँ मैं कि एक वीक बाद में
Yeah,
करते हैं.
yeah, yeah.
हाँ.
Okay.